Today, we will revisit two striking real-life cases from Taiwan's infection control history, to reflect on whether we have truly learned from the past, and to emphasize the vital role and responsibilities of the Infection Prevention and Control Committee. In 2003, Heping Hospital faced a major SARS outbreak. A single missed case led to over 150 infections. This event exposed serious IPC failures and changed Taiwan's infection control forever. On April 9, 2003, a 40-plus-year-old woman, Ms. Tsao, was admitted to the internal medicine ward of Heping Hospital. She had recently accompanied a family member at another hospital where SARS cases had been reported. Although she presented with fever and respiratory symptoms, she was not identified as a suspected SARS case. She was placed in a general ward, without isolation precautions or a chest X-ray. This carelessness became the turning point. The virus quietly entered the hospital and began to spread before anyone realized the danger. In mid-April 2003, a laundry worker at Heping Hospital began feeling ill. He was responsible for handling linens and clothing from patient wards, including items used by a SARS patient. At the time, many support staff had not received infection control training and were not equipped with proper PPE. Mr. Liu was later confirmed to have SARS and died from the illness. This case exposed a serious oversight. Infection control measures had not included non-clinical hospital staff. It served as a reminder that infection prevention must apply to everyone in the hospital, not just doctors and nurses. Ms. Tsao was placed in a general medical ward, sharing the space with multiple other patients. Doctors and nurses came and went, unaware that she was already carrying the SARS virus. There was no zoning in the ward, no separation between clean and contaminated areas. Patients used the same equipment, shared the same air. Some nurses wore surgical masks. Some didn't wear any protection at all. With inconsistent use of PPE and limited infection control training, the virus quietly spread. By the time staff began showing symptoms, it was already too late. As more staff and patients began developing fever and cough, tension inside the hospital escalated. On April 24, the government made a swift decision. The hospital would be locked down completely. There was no pre-triage, no evacuation. More than 900 people were trapped inside. Infected individuals, unconfirmed cases, and healthy people all mixed together. Inside the hospital, there was no clear command system and no emergency response plan. Staff were confused. Communication broke down, and essential supplies and isolation measures couldn't be implemented. In the chaos that followed, the virus spread faster than any response could. After the lockdown, the virus spread rapidly throughout the hospital. There was not enough PPE. Many staff had to reuse masks and gowns, day after day. The workload was overwhelming. Exhausted and sleep-deprived, the healthcare team pushed on. Some nurses cared for confirmed SARS patients, then moved on to other wards. Because there was no zoning within the hospital, clean and contaminated areas were not separated. In such conditions, not only patients but staff also began falling ill. What could have been a contained outbreak turned into a full-blown collapse. By the time the outbreak was brought under control, Heping Hospital was devastated. More than 150 people had been infected, and over 30 lives were lost, including dedicated healthcare workers. It wasn't just a public health failure, it exposed critical gaps in the healthcare system. The government and medical community responded with major reforms. Infection prevention and control committees became a legal requirement in hospitals. Routine PPE training and zoning systems were standardized. A national outbreak response plan and drill system was established. These changes were hard-earned, paid for with lives, and every healthcare worker who stood their ground during the crisis became a quiet hero of that time. The key failure points during the Heping Hospital SARS outbreak, and what the IPC committee should have done. Phase 1, April 9. The patient wasn't identified or isolated. The IPC committee should have enforced screening and early alerts. Phase 2, April 10-20. No zoning and inconsistent PPE use. They should have implemented zoning and PPE training. Phase 3, April 24. Lockdown with no separation or triage. An emergency plan and isolation protocol were needed. Phase 4, post-lockdown. Staff exposed, PPE reused, uncontrolled spread, ongoing outbreak monitoring and resource coordination were essential. In short, the IPC committee plays a critical role in prevention, planning, and rapid response. The second devastating case. In 1965, the World Health Organization officially declared Taiwan as a malaria-free region. Nevertheless, imported malaria cases still occur, mainly from Southeast Asia, Africa, and Oceania. In 1995, Taipei Veterans General Hospital faced an unusual malaria outbreak. 6 patients at Taipei Veterans General Hospital were diagnosed with malaria. Strangely, none of them had traveled abroad or to malaria-endemic areas. Upon investigation, all of them had CT scans shortly after Mr. Lee, a patient with recent travel to Africa, who was later diagnosed with malaria. To reduce costs, the hospital had not used single-use injection sets or tubing. Instead, they reused spiral catheters and contrast injection equipment between patients. Residual blood from Mr. Lee likely contaminated the contrast tubing, and subsequent patients were infected with malaria via intravenous injection. This incident shocked the medical community, becoming one of Taiwan's rare hospital-acquired malaria outbreaks unrelated to mosquitoes. This event led to unprecedented legal consequences. Dr. Chang, radiology director, allowed the reuse of contaminated injection equipment without proper disinfection. Sentenced to 1 year and 6 months in prison, no probation. The first senior doctor in Taiwan jailed for medical negligence. Dr. Lo, resident, failed to recognize infection risk and neglected disinfection procedures. Sentenced to 1 year and 4 months in prison. Dr. Lai, resident, overwhelmed by pressure after the outbreak, he died by suicide. His death raised awareness of the psychological toll on healthcare workers after medical crises. The key failures that led to the malaria outbreak at Taipei Veterans General Hospital. CT scan procedure. Reused injection tubing caused cross-contamination. The IPC committee should have enforced single-use policy and performed disinfection audits. Equipment management. There was no proper disinfection or IPC training for non-clinical staff. They should have trained radiology techs and clearly defined disinfection protocols. Cost-cutting decisions. Safety was compromised to reduce costs. The IPC team should have been involved in risk assessment and decision-making. Bottom line, even one overlooked detail like tubing reuse can lead to a serious outbreak if IPC is not embedded in daily operations and decisions. What is the IPC committee? It's a multidisciplinary team that leads hospital infection prevention efforts. Their job is to plan, implement, and monitor infection control policies. They also act as a bridge between hospital leadership and frontline staff, ensuring infection control is practiced consistently at every level. In many countries, including Taiwan after SARS, having an IPC committee is not just recommended, it's a legal requirement. Here are the main responsibilities of the IPC committee. First, they develop and regularly update infection control policies and SOPs, making sure they reflect the latest science. They monitor surveillance data, identify patterns, and report outbreaks quickly. They train staff on key practices, hand hygiene, PPE use, and patient isolation. Routine audits are done to check if staff follow protocols and the environment is safe. And finally, the committee guides emergency planning for outbreaks, ensuring a coordinated response. Together, these actions protect both patients and staff from healthcare-associated infections. Who makes up the IPC committee? It's a team effort involving both clinical and administrative roles. The IPC nurse leads daily operations, from audits and training to surveillance. The infectious disease physician offers clinical guidance and helps interpret outbreak data. A microbiologist supports lab testing and analyzes pathogens. The hospital administrator provides resources and ensures leadership support. Head nurses or unit leaders make sure protocols reach frontline staff, and environmental services ensure proper cleaning and waste handling. Each role is essential because infection prevention only works when everyone plays their part. Why is the IPC committee so critical? Because it protects both patients and staff by preventing infections. It also helps reduce hospital costs and avoid unnecessary treatments. In emergencies, it builds resilience and ensures the hospital can respond quickly. It helps hospitals meet legal and accreditation requirements. And most importantly, it fosters a culture of safety across all departments. Before we close, I'd like to share a quote from Henry Ford. "The only real mistake is the one from which we learn nothing." Every outbreak, every near miss, is a reminder that as long as we learn, it is no longer a mistake. And as long as we improve, it does not have to happen again. I hope that what we discussed today will help us build a safer and more resilient healthcare environment for tomorrow.